Josh, the one of the most exciting things that's happening throughout oncology, I think, is the immunotherapies. That's your particular specialty. What excites you in immunotherapy for follicular lymphoma?
Ian, as you know, I'm easily excitable, so the answer is everything.
That was a setup. I'm sorry.
It was. I appreciate that. If you said it, I'll, even at my height, try to spike it. Okay. So we know that, it's not an opinion, it's a fact that T cells can kill cancer, but they can kill low-grade lymphoma specifically. You can see this very easily in the small but impressive CAR T cell trials for follicular lymphoma. So if you can get a T cell sufficiently excited, clearly they can kill higher grade, but also low-grade lymphomas thoroughly and give durable responses. We've seen these in small data sets. So it's about how can we get those T cells to hate those cancer cells in the first place. I will say that, as opposed to the anti-PD-1 revolution in much of oncology, PD-1 monotherapy has been underwhelming in follicular lymphoma, the other low-grade lymphomas. We have a few patients who have long-term remissions. Probably everyone has, from some trials, people in remission for a few years. But the response rates are low, so how can we improve those?
Well, why is it low to begin with?
That's, wow. I'm checking the time. So I'll tell you why it's not low, because we have predictors for PD-1 response in other cancers. Some of those predictors are tumor mutation burden. If there's not enough, we think, neoantigens for those T cells to recognize, they won't be able to attack the tumor. Neoantigen burden or mutational burden is a good predictor in other tumors. So it's not low because follicular lymphoma lacks neoantigens or tumor mutation burden. It has comparable to some of the other responsive tumors, melanoma. And similarly, some of the other predictors for PD-1 responsiveness, CD8 T cell infiltration into the tumor, PD-L1 expression by the tumor, sort of we say interferon gamma signature within the tumor. Follicular lymphoma has all those things, so it should be responding. So why isn't it responding? Some difference in perhaps the T cell activation state. That's kind of a vague term. And there's one other great correlate that's been seen in other tumors for who will respond to PD-1 blockade. And this is some work by University of Chicago, Tom Gajewski and Stephanie Sprenger, showing that it's not just about the tumor having antigens, it's about the tumor having antigen-presenting cells, dendritic cells. Specifically, we call this BAT-F3 subset of dendritic cells. In other tumors, in multiple other tumor types, BAT-F3 dendritic cell transcriptomics in the tumor were a great predictor of responsiveness to PD-1 blockade. So maybe just by increasing dendritic cell infiltration to those tumors, we can get those checkpoint blockade therapies to be highly effective. Lots of ongoing trials of approaches like that. Intratumoral STING agonist, intratumoral TLR agonist into the tumors combined with PD-1 blockade. Early promising data about that. And then the other approach is just to combine with something that we know will get some effector cells into the tumor, obvious thing being rituximab, which will bring NK cells and perhaps other inflammatory things into the tumor as well. So, we sometimes say that the field of immunotherapy is PD-1 plus X equals dollars. That's a bit mundane, I apologize, but solve for X. So yeah, X could be rituximab, X could be some of these other things, but we have ways of, we think, improving the efficacy of PD-1 blockade or checkpoint blockade generally, and probably not increasing toxicity very much. We have some early data at ASCO, for example, about the rituximab plus PD-1 blockade, rituximab plus pembrolizumab, and we have this early study of rituximab, Gazyva plus obinutuzumab plus bendamustine plus atezolizumab PD-L1 blockade, both with pretty promising early data.
So do you think I always think of chemotherapy as being immunosuppressive. So you think, is that a concern?
I think it absolutely is, and chemotherapy can be immunosuppressive, but all chemotherapies are not born equally with this. So, on the immune system
bendamustine
side,
kills T cells.
Absolutely.
Right?
Bendamustine is not any immune cell's friend, really. But some other chemotherapies actually could be. So people have taken a very open-minded approach to this in the lab, using large panels of different chemotherapies. This actually, some of these best studies before bendamustine was widely used. So one of these studies, Dr. Obi et al. Nature Medicine 2005, comparing many chemotherapies to test not on the T cells, immune cell side, but on the tumor cell side, which induced immunogenic cell death. And the top of that list was anthracyclines, which was news to me. I never knew that before that study. And they actually had a correlate for which the immunogenic cell death chemotherapies can be read out by those that induce more calreticulin on the T cells. So we don't have to maybe do this big study again. We can, even in a test tube, maybe test novel chemotherapies for their induction of calreticulin on tumor cells. This is across a few different tumor types. So it was true in melanoma, colon cancer, and some lymphoid malignancies as well. So some chemotherapies could combine well. I agree with you that bendamustine is concerning, and it is amazing, or interesting, provocative, let's say, that just the rituximab plus PD-1 early data looks to be comparable, not a head-to-head study, of course, as the obinutuzumab plus bendamustine plus atezolizumab data.
Hey Matt, what about CAR T cells? Where you know, Josh just gave us eloquent need for engaging the T cells, and CAR T cells are obvious choice. It's working in large cell lymphoma.
Yeah, CD19 still sits on the follicular lymphoma cells, so I think it's going to come down to the risk-benefit. You know, can we find the right population of follicular lymphoma patients that deserve a try from CAR T cells? And I think we've talked about the early relapsing population. You know, if they continue to go down that track, I think that might be the place to go after, or people who are having short remission durations. But I think we're sorting out the toxicities. We're getting better at doing CAR T cells. You know, we're getting into the frame where you can have in one hospital 3 constructs. You know, whether or not it's 2 approved and 1 on clinical trial, that can now happen. You know, so we're getting there, and I think it's just a matter of time. I mean, it's already in clinical trials. It's just a matter of time till we are able to have those discussions also with the patients with relapsed refractory follicular lymphoma.
I mean, I agree with Matt that finding the right patient for the current, you know, risk-benefit ratio of CAR T cells, but then also the generation 3.0 CAR T cells will have a different risk-benefit ratio for everyone. They will be safer, lots of examples of that, but one of them is not very far along yet, is the suicide switch, modulator switch CAR T cells, like the inducible Cas9 or other similar technologies, where we can turn off the CAR T cell either when it becomes toxic or even before it becomes toxic. Once we make safe CAR T cells, it'll be easier logistically, maybe not financially, to get them in for patients with low-grade lymphomas.